Hello, we're going to
Hi,
get
every-
started today.
Hi,
Uh,
everybody.
we're welcoming the Perry community. We're bringing you today a conversation amongst friends. Dr. Flagg and I have been friends for over 20 years, and we've often talked about complex situations. We're both passionate about menopausal care, so we're here to answer some of the myths and truths about hormone therapy. I am Robin Noble. I'm a gynecologist based in Portland, Maine, with 20 years of experience at Intermed, more than 20 years of experience at Intermed. I'm the medical director of the OR up there, a physician leader. I have some other interests in that I recently completed a master's degree in healthcare delivery science. So I'm really hopeful that I can make some positive changes in what's often a broken system in the United States. I'm also one of the people that helped launch the nonprofit Let's Talk Menopause, and I am their chief medical advisor with a passion for improving the awareness and the empowerment and the equity surrounding menopause. And now my friend Heidi.
Hi there. I'm Dr. Heidi Snyder Flagg. I'm a board certified obstetrician, gynecologist, and menopause specialist, founder and managing partner of Spring OBGYN, which is based in New York City and founded in 2002. I'm very passionate about menopause. I've been working in the space for well over 10 years since I went off the obstetric call schedule. And I'm here to have a little chat with my friend Robin about myths and truths of hormone therapy, and we'll get started. So we'll take the first slide. So I'm going to just jump in here and talk about definitions because I think it's important. And in the OBGYN community, definitions tend to evolve over time, although it seems like molasses sometimes. Hormone replacement therapy is the term that everybody is familiar with. And of course, the touch point for the Women's Health Initiative study and the thing that we identify with, but actually it's a misnomer. We're not replacing people's hormones. We actually only do that in a couple clinical scenarios with premature ovarian insufficiency and surgical menopause in young patients. And some people take an issue, Dr. Jen Gunter in particular, but many others take issue with the implication that women are no longer women after menopause, that we have to replace their hormones entirely, and that sometimes people have issues with that. So the new term that we are working with these days is menopausal hormone therapy. So you'll hear that term out there. Robin and I have talked about this a lot. It's more accurate in that it implies that we're treating symptomatic menopausal symptoms, basically. But we feel like it doesn't include everybody. In particular, I'm going to say hello, Perry, to all of you in the chat here and who are going to listen to this. Symptoms for menopause occur much earlier than at menopause and beyond. As we know, it can be a 4 to 10 year process. So we feel like that doesn't include everybody. We'll take the next slide, please. We feel like the best term is hormone therapy. First of all, it's short and sweet. And when we have 15 minutes with our patients, we like short and sweet so that we can try to explain things simply to you. And we feel like this includes everybody. So the perimenopausal patients, our menopausal patients, and our trans male patients, quite frankly, who suffer with some menopausal and perimenopausal symptoms as well. So we want to include everybody here. So that's the basic overlay. I wanted to share one very funny caveat from the Menopause Society meeting. Dr. Stryker from the Midwest, she's a menopause specialist and a sex therapist specialist. She has rebranded hormone replacement therapy, HRT. She basically prescribes this HRT to patients whose partners can't seem to find the clitoris, and she prescribes HRT and she calls it husband replacement therapy. So I really appreciate that rebranding effort and think we should all use it that way these days. So we'll take the next slide.
Well, I would say back to kind of the sense of inclusivity. I don't really think we should be talking about husband replacement therapy. I think it's a funny joke, but I think, in all seriousness, partner replacement therapy can be necessary in some relationships. We all know that. But I do think we need to simplify things, not make things confusing. And hormone therapy is just an easier term to understand. So one of the common misconceptions about hormone therapy is that it's really only just for hot flashes. And that's really not true. And it shouldn't be that somebody has to have sufficiently bad enough hot flashes to consider hormone therapy. We know that hormones impact every system in the body, and people have various symptoms that can be related to their skin, their vision, their skin, their hair, their bone health, is a consideration as well. And many people don't know that hormone therapy in the United States has an FDA indication for the prevention of osteoporosis. So for example, anybody could elect to use hormone therapy, even using a strict FDA definition, for the prevention of osteoporosis. So I really think it's harmful for people to think that hormone therapy is really just for hot flashes, because it can be used for so many other bothersome symptoms. And I think it should be one of the things in our armamentarium of options, because one thing I emphasize with my patients is I really think that we need to individualize care, and there needs to be a lot more shared decision making and education and empowerment. So my goal is to explain things to people. This is one of the reasons why Heidi and I enjoy talking about these myths, and explain things to people so that we understand what the various implications of things might be, what someone's past medical history or their risk factors, and how that might inform their decisions during this very challenging time. So we'll go on a little bit further to the next slide and talk about other myths and misconceptions. So Heidi's going to take this one. This is another hot topic that I'm sure all of you have questions about.
Exactly. And I just wanted to throw in one more thing about the hot flashes that, that's the one thing that we identify with perimenopause and menopause. But there are over 150 documented symptoms, if not more, and I don't even think we know the half of it. So, and Robin certainly mentioned some of the important ones. So the next slide here is really important. I think the myth is natural products are safer than synthetic hormone therapy, and that's absolutely a myth. The term out there in the ether and around is bioidentical, which really is another complete misnomer. None of these estrogen products in any form are exactly what is in your own system. We try to get pretty close. And the problem this is with the bioidentical language is that it's really a marketing term to try to convince you that things are safer, and they simply are not. These things that are compounded in pharmacies are not FDA approved, and we can't really test them. And we consider it, and that's why Robin and I, and in the medical community, we choose to treat patients with FDA approved options. And for hormone therapy, we have plenty of options that are FDA approved. We'll go into that later. And the thing about, and I do want to say, though, there is plenty of room in the medical community for compounded medications that are not available to us. But in the case of hormone therapy, we have plenty of FDA approved options. So I just want to emphasize the fact that bioidentical is a misnomer. It's not identical at all to really what's in your system. The term we should really use is biosimilar, and we use micronized progesterone and ethinyl estradiol as those two.
I'm going to jump back in here just to clarify, and Heidi and I do this a lot. We'll jump back in if we have this burning desire to interject something, because we are good friends and we both kind of interrupt a little bit. But when we say natural products, I think what Dr. Flagg is referring to is more, she's referring to more compounded hormonal medications. And I apologize for that ringing. But one thing that varies in the US system versus in Europe is that there are natural products that are supplements that some people also might have questions about. Black cohosh and soy products and Relazan, other things. So one point to just point out here is that in the US, these things really aren't regulated well. And in Europe, there's far better regulation. So for our European community, there are more options that could be natural supplemented products that are more rigorously studied. So I think we were talking primarily related to bioidentical things and hormones rather than just supplements and natural products.
Right. I was just going to add, Robin, we mentioned this, that chondroitin sulfate, which is a supplement here in the United States for joint pain. They did a study and they tested, I don't know, tens to hundreds of different chondroitin sulfate products here in the United States, and found literally not one of them had in them what they said they had in them in the bottle, with the exception of one, and that was the one from Costco. And I have no financial interest, by the way, but so that I just wanted to point that out. The inconsistency in some of these products is really important. So do your research.
Just beware. Yeah, beware, and they're not safer and they're not superior.
Exactly.
Go to the next slide.
Go to the next slide.
So I'll take
this is yours, Robin. Yeah,
exactly. So getting back to that, hormone therapy does not need to be expensive. And unfortunately, too many people are kind of, struggling to get access. And that's, more of a systems problem in the US, that more people aren't trained and comfortable doing hormone therapy. But you shouldn't have to be paying for a subscription fee to see somebody periodically to get a lot of testing. You shouldn't have to pay for a custom compounded option that's more expensive. And compounded medications are not covered by insurance. So again, this is more to the US community, but you shouldn't necessarily have to be paying out of pocket. Now, there are a few exceptions. One is that there isn't an FDA regulated testosterone option for women, and we can talk a little bit about that later. So that is one thing that we either use off label or go to compounding pharmacies. And we have some lovely partners that are compounding pharmacies, or if someone has a particular allergy or insensitivity. So there is a place for it, but this should be the exception and not the rule. And really, hormone therapy should be at your local neighborhood drugstore. And most of these options are covered by insurance. And there are huge ranges in what I call kind of the Rolls Royce options versus the more, more common, less expensive. So for example, I always tell my patients that, single options like transdermal estrogen with oral prometrium at night is a lot less expensive than, say, a combi patch. So there are more expensive, more convenient options, like some of the vaginal rings are super convenient that people can use once every 3 months, but that's going to be really expensive.
Did we lose Robin? I think maybe we lost Robin there. I'll just keep going here, and so I'm just going to keep going on the more expensive piece. One really important thing to do is to discuss with your insurance company, get online or get on the phone with them and get a list of covered medications to bring to your provider. I'm not sure where Robin is here. I'm gonna. So Laura, if you're still on, I'll go to the next slide. Actually, I don't know. I'm really sorry, Robin's not on. Somehow she froze here. So the next slide here is myth. You need to be seen frequently and have blood levels checked to measure hormones. This is really an important situation. Also, I think people are they sign up for these programs where they get their hormones measured, and there's really very little clinical value, particularly in the perimenopausal space and time period and even postmenopause to really help. We monitor these things clinically based on your symptomatology, and we don't, if you're symptomatic enough, then I'm sorry, Robin's just texting me here. If you're symptomatic enough, we will treat you regardless of what your hormone levels show. Hormone levels can fluctuate tremendously in a given day. They can be high in the morning and low in the afternoon. Estrogen has a 12-hour half-life, so it can titrate out of your system very quickly. And then to be seen frequently, it's interesting. I'm sorry, Robin's not on. Hopefully she'll sign on here shortly. But Let's Talk Menopause is actually about to release a really nice guideline that you can take, you can look at, and to help you with to see your provider, a menopausal specialist, hopefully, or your primary care physician, or whomever you have access to. But it's a guideline on how to proceed with seeing your physician in terms of how often you should see them and what questions to ask and what sort of things to have ready. And so basically, if you book a separate visit outside of your annual exam, because your annual exam, quite frankly, we have 15 minutes to cover a lot of different screening modalities, a lot of breast cancer, cervical cancer, ovarian cancer, and talk about health and exercise and all the social things that impact patients. So it's really important to maybe book a separate appointment that we can really focus in on menopausal symptoms and talk about what the best options would be for you. And then we do a 3-month follow-up. At 3 months is when your hormone therapy, you'll see the max benefit of that. So a 3-month follow-up. So basically a separate visit from your annual exam with a 3-month follow-up. And that should really Obviously, there are exceptions if people are having some side effects and those things need to be addressed sooner. But those are really the visits that you need to get yourself on hormone therapy.
And I might have missed that, Heidi. I'm sorry that dropped out. But
hi, Robin, there you are.
one thing is
Glad you're back.
I might have missed is you really treat to symptoms. So it's not about the level that you are, but it's really about how you feel. And I'm sure Heidi said that. So we can go to the next slide.
I did, Robin. The other thing I mentioned is Let's Talk Menopause is about to release a really nice guideline, which I know you've been heavily involved in putting together, about how to approach your physician and what you can do to get ready for that visit. So I mentioned that as well. You can find it on Let's Talk Menopause website soon, in the next week or two.
Good.
Yeah.
So this is something we had questions about as well. Many people are aware that there are kind of age guidelines surrounding hormone therapy from some data that came out that suggests that kind of the earlier, it's called the timing hypothesis, the earlier around that transition, the better it is in terms of kind of not only symptom management, but perhaps implications for heart health and brain. So you do not need to wait to start hormone therapy until someone's officially menopausal. That's kind of a misconception. You can certainly have a lot of help during that perimenopausal period and up until menopause, and then even thereafter. We had a question that we'll get into a little bit more about management of perimenopause and where birth control pills can sometimes fit in versus hormone therapy. But then we also had questions about how late is too late. And there's some guidelines that, it probably isn't a great idea to start after 10 years into menopause. And the rationale behind that is that we think some cardiovascular disease and some cardiovascular coronary plaques can occur in those ensuing years. And then starting hormone therapy later, say it's 12 or 15 years later, there is an increased risk of heart attack and stroke with a late start. So that's the concern. And perhaps we'll have time to get into that a little bit more. But there isn't a concern about starting it younger. In fact, many people need support through that perimenopausal phase. Starting at around the time of menopause is really ideal for that symptomatic control. And then there is a concern about having had a long hiatus from menopause and starting much later. For example, if someone's 65 or 68 and has not been on anything since a menopause at say 52, that's more of a concern and really needs to be individualized. Next slide.
But Robin, I just want to throw this in there that, you and I make shared decisions with so much of this is of such an individualized approach, and having a discussion with the person in front of us and comfort level and discussing risks and being really clear on that, and then making a decision together to proceed with hormone therapy. So if I have somebody who's willing to accept some risk and they're over 60, I'm willing to do that with somebody, as long as I really don't think that there's, major potential harm, and that they fully understand the risks, and that maybe we've done some screening tests to rule out cardiovascular disease, like a coronary artery calcium score and a workup with a cardiologist, for example. So I just wanted to throw that in there. That's a shared decision, which you guys will hear over and over and over again here. That's so critical.
And it reminds me, Heidi, too, that, when we talk about hormone therapy, very often they're localized things that, that is confusing for people, because local vaginal hormones are also really helpful. And those really are safe for nearly everybody in the population. There's even more safety data about breast cancer survivors and people with breast cancer, that there's almost no absorption, and it's a really safe option. So sometimes that person who's 15 years out from menopause, maybe systemic hormone therapy isn't the best choice for them. But again, as Heidi said, that's a discussion. Neither one of us would be somebody that would be withholding something from somebody if they really understood those risks. But it also might be a time where local vaginal estrogens could make more sense, where some of the non-hormonal therapies for hot flashes could make more sense. And there are even some of these very fancy selective estrogen receptor modulators that kind of hit the bone, for example, and the vagina, like Aspina. Aspamifene is the generic name. So there's some things and some nuanced management, but there really shouldn't be rules. So I think what we would say is, like, the myths are that there are rules, like under the age of 60 or within 10 years of menopause. We don't use those rules, but you will hear them as kind of guidelines. And I just tell my patients it's more controversial beyond 10 years. It's more controversial in these situations when some people have some increased risks of, say, clot or stroke or some of these hereditary disorders. But we don't tend to go by black and white rules. And I think that's helpful for people, and it makes people feel kind of included in that decision making.
Absolutely. Next slide. Yeah. Hormone therapy is only for women transitioning through menopause. I think we just covered that basically with being flexible and using these as guidelines.
But I guess this is a good opportunity too to mention that the other thing that really comes up and sometimes comes up in questions is how long can you do hormone therapy for? So I think this myth we were also thinking about, it's not only for that transition, it could be for 5, 10, 20, or even 30 years. You know, in both of our practices, you know, I have some patients in their 70s, 80s, and 90s that remain on hormone therapy, particularly if they've had a hysterectomy. We think all the data supports continuing on estrogen therapy, you know, particularly transdermal, is even safer, but there isn't a set rule of when somebody has to stop. There are times when it's worth revisiting. You know, perhaps we're aware that, you know, estrogen progesterone therapy together in theory seem to increase our risk of breast cancer after about 5 to 7 years of use. So I have some patients that after about 5 to 7 years, they end up deciding, you know, maybe I want to trial off and see how I feel, or because it's now considered more controversial over 60, I might have people that at 60 feel like maybe I'll trial off or switch to one of these selective estrogen receptor modulators. And I have other people that either try it or elect not to, and they continue for years and years and years. I know we had some questions about that. So again,
I would just want to jump in, shared decision making, but the Women's Health Initiative, the 20-year analysis, they really just looked at this, the estrogen progesterone, and the after 5 years of use with the average age of 60, we really think the risk is really only increased by 1 in 1,000. So, or maybe even 2 to 3 in 1,000 at most, but 1 in 1,000 is sort of when you really look at the data, and we've just been looking at it more carefully, did a 20-year analysis. So I think, you know, just in terms of our counseling, it's really important to explain that risk to patients rather than, again, have it be cut and dried, because really we're getting a lot more reassurance from the relook at the data.
Just to clarify, Heidi, what do you mean about that 1 in 1,000 risk of what?
So just after 5 to 7 years, if you look at the WTA, they just looked at that again, the 20-year out study.
But the risk of what?
Oh, breast cancer.
You mean breast cancer. So when we talk about these things,
that's the thing that everybody's terrified of, right?
Increased risks of breast cancer. And, you know, we know American women, you know, in particular, are very concerned about breast cancer risk. And we really do feel that those risks have been overblown. And sadly, too many women are not aware of things like their risk of osteoporosis and bone health, the risk of cardiovascular disease. So we really have to look at hormone therapy and management of menopause as a systems-wide approach, because even if someone elects not to do hormone therapy, they need to be aware that all of these risks for diseases like cardiovascular disease, diabetes, metabolic syndrome, and osteoporosis really abruptly change at menopause. So it's a time to really look holistically at someone's risk and what the options are for management.
And just to go back to Robin's point about the timing, if we start hormone therapy before any disease, cardiovascular disease in particular, sets in, estrogen is really protective, and then still the number one killer of women is cardiovascular disease, heart attack. So estrogen actually is protective and prevents cardiovascular disease. I have a slide coming up regarding that. So we'll go to the next slide, Laura, and thank you. Robin, I don't know if you want to touch on this. This is uterine cancer, breast cancer we've touched on, ovarian cancer. These were the missteps in the WHI study where we added progesterone, but so maybe you can comment on this one.
Yeah, I mean, this one, I think it's just important to speak to people's concerns, and often we're concerned, you know, can this increase our risk of cancer? The reason we use progesterone when someone still has their uterus is to protect the endometrial lining. In the 1950s, before we knew this, estrogen alone could vastly increase the risk of someone's risk of uterine cancer, but with progesterone, that really mitigates that risk. That's why we add a progesterone or use some of these newer agents that don't require that. And with that type of regimen, this doesn't increase our risk of uterine cancer. And as far as ovarian cancer, there was one study out of Europe that looked at estrogen alone for a long duration that perhaps had a very small increased risk in ovarian cancer. And most experts and gynecologic experts in the field feel that that's not a significant risk. We think it's a little bit of a confounder. Although I always counsel my patients, this stuff we don't have all the information on, but we don't think there's a significant increased risk in ovarian cancer when we use prolonged hormone therapy. Heidi, would you agree on that one? Is that how you counsel people?
Totally agree. Yeah. So we'll go to the next slide. If I had breast cancer, I shouldn't use vaginal estrogen. Robin touched on this one, and we just had a great talk on this at the Menopause Society meeting. So, and this is just amazing for people who have a history of breast cancer. Of course, I've always, for years now, I've worked with my oncologist and my patients who are really suffering. So the key here is that it's we do think, because of the lack of absorption into the systemic system through the vagina, that we can use low doses of topical estrogen on the vagina to help alleviate the symptoms of GSM that people suffer so tremendously from, particularly the breast cancer patients. So we're talking the low dose suppositories. They do caution against using cream because that is more potentially absorbed. The other thing that it's patient use dependent. You're filling up an applicator filled with the cream, and so that patients can use too much, and then insert it too deeply in the vagina. The upper third of the vagina, there's more absorption, so you keep it down in the lower third of the vagina. So you just insert it just into the vagina, and a little bit of the cream on the vulva is really helpful too. So a very low dose use of topical estrogen products on the vagina for our history of breast cancer patients is perfectly safe. And these studies just came out recently. So there's been a lot on the airwaves about this. And this is really a tremendous breakthrough, really, for our patients with history of breast cancer.
And I'll jump in here too, because I think this is a great opportunity to talk about the safety of these vaginal preparations in general. And I know we had questions related to, can I use these vaginal creams or suppositories in addition to systemic therapy? And absolutely, for more localized symptoms, these are very effective. They're tremendously safe. To underline what Dr. Flagg just said, that even in breast cancer survivors, we think minimal absorption. So especially for people who have not had a breast cancer, using these local topical vaginal estrogens are incredibly important for those symptoms that she mentioned. This new term, genitourinary syndrome of menopause, not my favorite term personally, but it really incorporates kind of vaginal dryness, pain with sex, urinary urgency, frequency. The risk of urinary tract infection increases in this situation, even certain symptoms of prolapse when kind of gravity and pelvic organs descend. So all of these things are issues that can be mitigated and improved with local vaginal estrogens. And even people who elect not to use systemic vaginal estrogen should consider local vaginal estrogens to improve a lot of these symptoms.
Agreed, Robin. And also, by the way, there's no timing on this. You can use topical vaginal estrogen until the end of time, as far as I'm concerned.
Good point. And no concern about starting it late either. So absolutely good point.
You can start at any time and use it until the end of time. Absolutely. So we'll take the next slide. This is that hormone therapy causes cardiovascular disease. This was the whole look at the WHI study. And I think Robin and I touched on this already in terms of the timing hypothesis. Getting this started before disease sets in is really important. I want to say something about estrogen. It's an anti-inflammatory and it's a vasodilator. Both of those things, inflammation and lack of blood flow, are implicated in heart disease. So estrogen can improve both of those situations. So it makes perfect sense that it actually is a preventative for cardiovascular disease. Robin, I don't know if you want to add anything else there.
Yeah, I'll jump in because I know we had questions that might be a good time to jump in related to hormone therapy and what reasons could I not use it, or should I not use it, or should I discontinue? Kind of like where are the black box situations where, you know, maybe it really isn't a good choice. And those are when people have had a myocardial infarction, if they've had a stroke, if they've had a pulmonary embolus, or a deep venous thrombosis that's been kind of unprovoked, wasn't caused by several other factors like immobilization, being on birth control pills, postpartum. But we're concerned about people that might have an increased risk of clot or stroke. And so that's something I think, and the other one is an estrogen receptor positive cancer. Those are pretty much those reasons where we really would not feel like it is wise to do that. But there are certain situations where there might be a slight increased elevated risk of clot or stroke, and we certainly prefer to use transdermal estradiol and transdermal estrogens, or observed through the skin. Transvaginal works as well, because they don't get metabolized in the liver the same way. So you'll hear this theme that oral estrogens and oral birth control pills increase the risk of clot and stroke, but we really think the data suggests that transdermal, or through our skin or through the vagina or the mucosa, really doesn't seem to increase that risk of clot or stroke. So in an older person, perhaps with higher risk of clot or stroke, or with a family history of various situations that make us feel more cautious about this, transdermal is always safer.
Agreed. And I just want to say one thing about saying that, the birth control pill causes clot and stroke. It's a little bit of an alarming statement. And it's really important to understand that it's almost increments of nothing in terms of the difference between transdermal and the oral preparation. It's true, like if you have any concerns, just go transdermally. But plenty of people are taking oral contraception, and plenty people are on oral HT hormone therapy, and we really do, obviously with the proper screening and all of that, consider it safe. So I want to emphasize that.
I think this is also a good time to kind of jump in and talk about kind of risks and statistics, because I think the media is partly to blame when they kind of overblow some of these concerns about how much does this increase our risk of clot or stroke. And these are rare events in healthy people, but I think it's really hard for us to wrap our brain around, like, what is the increased risk of, say, clot or stroke? And I recently saw that taking oral combination birth control pills, which many people have taken and many people continue to take, and frankly, it's been a huge innovation in kind of women's health and reproductive care, but that increases our risk of clot or stroke by 30-fold, 30 times. So when we talk about increased risks of clot or stroke, if we think about birth control pills being a 30-fold increased risk of clot or stroke, hormone therapy, especially transdermal, is nothing in that nature. It's probably on the order of like a 5-fold increased risk. Would you say, Heidi, too?
Yeah, it's funny, Ron. So there's baseline risk of, clot, and I've seen for birth control pills, it raises it 8-fold. And then for pregnancy, I always put it in the context of pregnancy, which is far greater risk for a blood clot, quite frankly, or pulmonary embolus. You're at 15-fold risks. Those are the numbers I've looked at. And when I counsel patients, I really try to use raw numbers, because I think people can just wrap their heads, rather than use percentages or whatever. But so I think if we actually were using the raw numbers, which quite frankly, I'd have to go back and look at them. I've looked at them, but I don't recall right off the top of my head what those actual raw numbers are. But yes, I
even
agree.
this conversation is just helpful for us to understand that kind of what we hear reported as like double the risk, quadruple the risk, 5 times the risk, or is it in 10,000 women year? It's really, really hard to wrap any of our heads, even when we've been trained in science and statistics. So I think we have to have our wits about us when we talk about risk and absolute risk. So really helpful to kind of understand that what we're afraid of and what our actual risk is. Frankly, we have more risks undertaking, using cars for transportation than we do taking hormone therapy. So I think we have to look at our lifestyle risk factors, our overall risk tolerance, and that's just helpful in the conversation.
Yeah, and I'm in New York City, and so I put it in the context of, look, you're running around New York City, you're on the subway, you're in a cab, and quite frankly, on a day-to-day basis, you take a lot more risk doing that than getting on some hormone therapy. So we just try to put it into a relatable risk category.
Exactly.
All right, next slide. We'll take the next. Oh yeah, here we go.
Okay.
Robin and I, this one.
I'll take this one. I mean, this is such a common concern. And, we often get questions. It's one of the common presenting symptoms that people are not only perhaps gaining weight, but having difficulty losing weight. They can't continue to eat the way they've been eating or drink the way they've been drinking, and weight just keeps coming on. Or more commonly, people also report around that perimenopausal and menopausal period that they start to notice it's going to different places, like it's going kind of more middle. And the reason that happens is that change in ratio of kind of estrogens and androgens. We tend to have a little bit more male pattern deposition of our tissue. Sometimes people notice the errant, hair around their chin, or the middle, increased tissue in the middle. And unfortunately, this is the more metabolically active fat that actually increases the risk of diabetes, metabolic syndrome, and cardiovascular disease. But there's this overlay of kind of chronologic age and all the things that are happening with our muscle mass and waning metabolic rate, in addition to some of these interactions with hormones. So hormone therapy does not cause weight gain. If anything, it tends to mitigate those changes. And when they look at trials of hundreds of women that are on hormone therapy versus hundreds of women that choose not to be, hormone therapy actually seems to be a little bit protective against some of that weight gain, but it's only on the order of about 4 to 5 pounds. So I tell my patients that weight gain is a problem around midlife for multiple reasons. Hormones are involved. Hormone therapy does not cause weight gain, but it's also not a weight loss regimen. It kind of mitigates some of those changes if that's helpful, but this is really a time to kind of step up our kind of workout intensity, try to build more muscle mass. It's helpful for bone health, and also look at kind of how we're eating. And it's really that time in our life where we need to double down on kind of healthy lifestyle changes, increase that protein intake, try to do some more intense workouts if we can build some more muscle mass. Heidi, how do you counsel your patients?
I'm basically exactly that, but it's not to rely on hormone therapy as a weight loss tool, but it could certainly help maybe slow it down or help with some of the redistribution. It just depends on the person who you give it to, but sometimes they'll get their waistline back a little bit. Also, not for nothing, but it makes them feel so much better and their moods improved and all of that they can get themselves out there and exercise a little bit more. I think weightlifting is really important, and building muscle, maintaining muscle mass and building muscle. Cardio, actually, too intense, I think, works against you a little bit because of the cortisol release. So gentle cardio, but certainly moving. I think walking is wonderful, but I think it was 300 minutes a week, something like that. And then in terms of nutrition, you can do a lot there. You just can't get away with what you used to. So you really have to eat cleanly, the Mediterranean diet, and make sure that 30% of your calories are protein. So it's protein, moving, stress management and sleep, quite frankly, also play a major role in weight gain. So sleep is another topic that we could.
Two things I jump in there. Absolutely. I was thinking of sleep because it's intimately involved in kind of our metabolism, how we eat, how we process calories, or satiety. But you also made me think of, this is a time to actually talk about, we have whole new classes of medications that are actually really helping people lose weight. It'll be really interesting to see how that plays a role in getting weight off people, changing their risk factors for cardiovascular disease. We think there are connections even with dementia in terms of weight and this metabolic fat. So I think there are going to be interesting collaborations with kind of weight management, hormone therapy, and again, really need to look at it as a holistic picture.
Agreed. We'll go to the next slide. I think we've got to getting close to being done here. This is a great one. Hormone therapy is the only thing that works for hot flashes. We have several other options, and Robin speaks really beautifully to this. So I'll let her talk. This is the fancy estrogens, as she calls them, the SERMs, the brand new candy receptor blockers. So Robin, I don't know if you want to touch base quickly on this, but
yeah, I mean, in general, there are lots of options for hot flashes. It doesn't need to just be hormone therapy, but this is obviously about the myths of hormone therapy. But CBT, SSRIs, SNRIs, these selective estrogen receptor modulators, I call almost fancy estrogens because they work as estrogens in certain tissues of our body, and they kind of bypass or don't positively impact, say, the breast or the uterus. And we're seeing some combinations. It's a great option for people. However, it's expensive, it's oral, and there are not a lot of doses. So currently it's bazodoxifene paired with Premarin, which is generated basically from pregnant horse urine. So I'm not, personally a great fan of harvesting estrogens from pregnant horse urine, but that's what we have. So we do have some selective estrogen receptor modulators paired with pregnant horse urine that can actually benefit the bone health, hot flashes, brain, vagina, and not increase the stimulation of the breast tissue or the endometrial lining. So those are some interesting options. I think we'll see more in the future.
Yep, for sure. There's a lot. You won't go to the next slide. Hormone therapy is a cure-all. It's not. I think we've touched on this, that it's a combination of lifestyle factors, sleep, stress mitigation, all of those things in combination. It's unfortunately, the analogy I use with my patients is you're driving along with you're driving the car along at about 55 miles an hour. And in order to keep that car at 55 miles an hour, you got to press harder on the gas pedal. We have to pay attention to what our body is saying and telling us. And we have to make sure we really support these lifestyle issues so that we can transition through this as optimally as possible. Robin, I don't know if you want to
Yeah,
add
and
how
I
much
might
that
jump in here
matters.
too, because I tend to, it's not a cure-all, but it can help an awful lot on so many. It's really the only thing that touches so many of these systems. So I'm a big believer in trials, and I always tell my patients, you're the expert in how you feel. And if somebody's on the fence, if they're interested, if they're wondering how much of this is all wrapped up in hormones, that if they're a good candidate for hormone therapy, sometimes it's a trial period, and somebody tries it. And I have the benefit of seeing people come back to my office. The vast majority will tell me that their symptoms are significantly improved and they feel a lot better. They feel back to themselves, or they feel, that they have their feet under them. They don't have the same issues. But occasionally I have people who come back and they've tried it and they're like, it really didn't help me. It really didn't seem to make any difference, and I want to continue. So I fall back on, how do you feel? What's important to you? What's your philosophy about management in this time? And there are lots of different options that we can do, and lots of different angles. We can take, I had somebody come in yesterday that said, I really want to be more natural. And we kind of went through what would be the natural things in her frame of mind, like cognitive behavioral therapy, hypnosis. We've got some good data for that, whether, supplements or something she wants to explore. But ultimately, she came full circle and wanted to do a trial in hormone therapy, because in many ways, when we think about medications versus hormones versus natural versus, what is aging, I think these are difficult questions that we wrestle with. And I personally enjoy kind of teasing that out. How do you feel about menopause? What do you think is really happening? Do you think we were meant to live till 80 or 90 with basically very little hormone production from our ovaries? How do we think that would look like if men's testicles stopped producing estrogen testosterone at 50? How do we think we would handle it if men's testicles just petered out? Would we just say that's normal, that's okay, this is a choice? Somebody told me recently, they said, no, I think we'd have a vaccine for that. So I think a lot of it has to do with kind of our outlook, our philosophy, aging, and really we should be empowered to have the menopause management and the menopausal transition that we want. And we're there to kind of help answer these questions. I'm going to take a quick run through of any questions we might have forgotten.
Laura, go through the next slide. It's just a quick summary, I think. If you go to the next slide for me. Yeah, not the same for everybody. I think this clearly it's individual. And then here we go. Shared decisions with a trusted provider. One size does not fit all. There's no magic bullet, and you need a combination of hormone therapy, lifestyle modifications. Hormone therapy is safe with the correct timing, mode of delivery, health screening, and personalized care. So those are the things we wanted to emphasize. And Robin, you can. Yeah,
I love it, Heidi. You summed it up. Got me back on track. So I'm going to throw one at you that came through in the questions. Is there a particular ratio, Dr. Flagg, between estrogen, progesterone, testosterone? How can you manage this ratio? How would you answer that?
Interesting. We have lots of study data and FDA approved doses that we basically start with. And Robin, I don't know how you tend to do this, but our 0.625 or 0.05, the combi patch dose or the estradiol dose, it's pretty standardized. And then we, again, as Robin says, the patient is the best investigator of how they're feeling, and let us know how they're doing. We can go titrate up or down a little bit as needed. So basically, we have sort of standardized doses that we do start with, and then we go from there. And that's that follow-up in 2 months, 2 or 3 months, actually. 3 months is when I usually see people back, and obviously take questions in the meantime, but I'll start them on hormones, see them back in 3 months, and we kind of touch base and see how we're doing with that. I don't know, Robin, if you want to add.
Yeah, I'd pipe in there and say, so I think what Dr. Flagg is saying, and I would agree, is there isn't a standard ratio that we know of that's better than anything. My biggest concern with the progesterone is that we're definitely getting enough adequate progesterone to protect the endometrial lining, which is why I get concerned if someone's doing some compounded transdermal progesterone. We just don't know that you're getting adequate progesterone to protect that endometrial lining from an endometrial cancer. We didn't touch on, but a great option too is the levonorgestrel IUD for progesterone support of the endometrial lining. So that's there's no ratio that we know of. It is about individualizing the care to symptoms. I'm going to run through the next questions. We covered, yes, it's okay to use vaginal with or without systemic transdermal or oral systemic hormone therapy. Oh, we didn't talk about the oral contraceptives around perimenopause versus HRT. Did you get that, Heidi, when I dropped?
And big different, well, I think because we have just a minute or two, but quickly. So the birth control pill is basically a higher dose. It's essentially similar formulations to hormone therapy, but just a higher dose to provide birth control. And when you're perimenopausal and still menstruating and not that full year past that last period, you do need birth control. So that's why we often use that. And it's just a really wonderful way to get people from 40 to 50. I use it all the time. I use the lowest dose, low estrogen. They barely get a period. It controls their period bleeding. Often perimenopausal women will suffer tremendously from super heavy periods and cramping. And it really is incredibly helpful. I mean, we have other tools, but that's, and then
difference I explain too is that birth control pills suppress our ovarian function. So really important when the ovaries are still competing. In menopause, you don't need to suppress ovarian function, so those doses can be lower. Two quick things, and then I want to summarize because we don't want to keep anybody longer. But oral progesterone is typically given at night because it helps people to sleep. That was another question. And then we had a question about, I have hot flashes and I'm allergic to epinephrine. I'm not aware of any reason you couldn't use systemic hormone therapy for that. And then lastly, in closing, I want to thank the Perry community for inviting us here. We really hope this was helpful to many of you, the listeners, but I also want to in closing give you a couple of reference points for more information.
Sorry, Dr. Noble, this is Laura. One more question came in from Julieta.
Sure.
It's in the chat.
In the chat.
If you can see it.
One more question. Can you read it to me, Laura?
Varicose veins.
If you have varicose veins, yes.
Yes.
Not a contraindication. You can use
transdermal would be a better option, but absolutely not a contraindication. Perfect. So I would send you to menopause.org. That's the Menopause Society. I would have you look at our Let's Talk Menopause.org, as well as obviously our resources on Perry. I'd also have you look at emas-online.org, which is the European Menopause and Andropause Society. That's a nice reference point, as well as the International Menopause Society, which is imsociety.org. So you've got menopause.org, Let's Talk Menopause.org, emas-online.org, and imsociety.org. So more resources, you can find us. You've got the Perry community and resources there as well. But we hope this was helpful and happy reading, and we hope it was informative.
Thank you for having us, Laura. Appreciate it.